Good day, everyone. This is Senior Clerk Cubelo for another episode of Med Talks with Murray. For today's episode, I will be performing endotracheal tube intubation. So these are the indications of performing an ETT, which includes AGCS-9, flail chest, respiratory failure, aspiration, drowning, and ruptured diaphragm. To begin, assess the patient with the help of the mnemonic LEMON. L. Look externally for signs of difficult intubation, such as those with large tongue, short neck, obesity, dentures, and large incisors. E. Evaluate for the 3-3-2 rule, which is an assessment tool used to predict difficult intubations. This functions to estimate whether the anatomy of the neck will allow for appropriate opening of the throat and larynx. 3 stands for 3 finger breadths for the mouth opening. The second 3 stands for finger breadths for the hyomental distance, and 2, which means 2 finger breadths for the thyromental distance. Third, which is letter M, we assess for the Malampati score. We ask the patient to stick out his tongue and assess the oral cavity. The higher the grade, the more difficult is the intubation. Fourth, next we assess for any signs of obstruction, such as tumor, abscess, foreign bodies, and expanding hematoma. Lastly, N, neck mobility is checked. So that means lemon. For the materials, for the equipment to be used, we remember the mnemonics MAIDS. M stands for monitors, including the cardiac monitors and pulse oximeter. A stands for airway equipment such as laryngoscope, stethoscope, endotracheal tubes, and the bag valve mask resuscitator. I, which stands for intravenous fluids. D stands for drugs, which includes the neuromuscular blockers and sedatives. And S stands for suction, including the suction machine and catheter. For the proper positioning of the patient, we place the patient in a sniffing position. This is done by placing a pillow under the head in order for the lower neck to flex. Then let the patient fully extend the neck. With this position, you obtain a good line of vision because the oral and the pharyngeal as well as the laryngeal axis are all in line. Next, basic airway. First is to suction the secretions to prevent obstruction of the airway. Perform a head lift jaw thrust maneuver in order to displace the tongue anteriorly and place the bag valve mask, starting at the bridge of the nose and lowering at the patient's mask over the patient's mouth. Perform the CE grip by placing the middle and little finger under the mandible and pulling it upwards. Index and thumb should create a C, and begin ventilation for a few minutes once the proper seal is achieved. Let the patient breathe 100% oxygen for 3 minutes. Prior to insertion of the oropharyngeal airway, the Celix maneuver is performed to help align the airway structures and reduce the risk of regurgitation. This is done by applying a gentle pressure at the level of cricoid cartilage. Open the mouth with the gloved right hand, scissoring 2 fingers by placing the thumb on the lower jaw and the index finger on the upper jaw. The laryngoscope is held on the left hand and is inserted along the right side of the mouth, pushing the tongue to the left. Visualize the glottis opening. The endotracheal tube is then passed at the right corner of the mouth, and the tip of the tube is passed through the glottis opening and is advanced by 2 cm until properly placed. Carefully remove the laryngoscope and inflate the cuff using the 10 ml syringe. Remove the stylet carefully while holding the endotracheal tube. Attach the tube to the bag valve mask resuscitator for oxygen. Check for chest expansion. Anchor the ET tube and evaluate the placement of the tube by auscultating the chest as well as the epigastrium. Equal breath sounds must be heard over both lung fields. And once correct positioning of the tube has been confirmed, connect the tube to a mechanical ventilator and plaster the tube in place. You can obtain a chest X-ray if possible. That's all for today's episode. I hope you learned a lot. See you in the next episode.